Good evening, everyone. I'd like to call the Community Mental Health Full Board Meeting to order. We need adoption of the agenda. Moved by Birdie, supported by Brown. Any questions or discussion on the agenda? All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is hearing of the public. Is there anyone from the public that would like to address this body? You have 5 minutes if you'd like to speak to this body.
Right now?
Yes, right now, please. If you could come up to the microphone here.
That's good.
Sir, if you could please come up to the microphone so we can all hear you.
Working on it. David probably won't be able to get to the mic, maybe. I'm Robert Blumingberg. This is my brother, David. David has been receiving community living support through self-determination, through vocational day programs for about 9 years now. And first, we're not here to complain. Actually, we're here to ask a couple of questions and actually compliment the services that Dave has gotten over the years. And Dave would like to speak first. Go ahead, Dave.
My name is David Bloomberg. I worked at the Art Service for 33 years. I retired 9 years ago. And I have a lot of people who volunteered to help me, to take care of me, and do all the work. And I've been doing a lot of exercises in my arms and legs. And I've been going a lot of different little places. But I need more volunteers and more people to be working with me. I had Sandy, Howie, Carla. They all did a good job in helping me out. But I need more volunteers so my brother can. I don't need my brother to help me, but I need my brother to go to school and go to work and make some more money so I can have somebody to help me out.
In summary, David's been getting community living support for 9 years, and he's very fortunate because we were able to get a decent number of hours for Dave where he really can live on his own and do everything that he wants on his own. 4 years ago, we had a Medicaid fair hearing in which Dave was given or granted the number of hours that he's been getting up until our previous authorization, or his previous authorization, which Dave's authorizations begin in the beginning of May and end at the end of October, 6-month authorization. The authorization that ended at the end of April of this year, we didn't have any problem with. And then the new authorization that we got that went from May until the end of October was fine until 3/4 of the way through through the authorization. And David requested to have some of his hours split between self-determination and an agency. And at the time we requested that, we weren't really, first of all, we didn't realize that Access Center could dock someone's hours in the middle of an authorization. So we requested to have Dave's hours split. And at the time we requested it, the Access Center granted Dave's split in hours, but they also cut his hours. And the communication between the Access Center and the consumers is very vague. And so we got a notification letter, and we talked to his supports coordinator, and they told us that that letter that we got really didn't signify anything, and that Dave's services or support was intact, okay? And so we come to the new authorization, and Dave's hours were cut. And so Dave gets, we were fortunate. Dave gets 133 hours a week in community living support. And those hours were cut to 101 hours a week. I understand that the county has monetary issues, and there's definitely things that need to be done to correct the county's fiscal problems. I just wonder, why is it that we chose this way to correct the problem? When I say that, we love community mental health. I have touted community mental health wherever we go. I said we've been so lucky that Macomb County Community Mental Health has been able to provide community living support and the things that they have for Dave. And up until this current authorization, we've had no reason to complain about anything. We're just so lucky that we've been able to get it. However, this time the authorization was cut, and we understand that everybody's authorizations were cut. But the way it was cut and the way we're notified of it, and then the way we went through this local disputes resolution hearing is really, to me, it didn't make any sense. And it caused, it almost like we have an adversarial relationship now between us and the Access Center and community mental health. And so on top of that, the supports coordinators are just so overtaxed, it's insane. They have more than they can handle, and then they're required to go to all of these hearings that are being required because everybody's services are being cut. And my question is this the best way to go about doing this? I mean, I understand that probably in the next authorization or after we go through Dave's Medicaid fair hearing, that the facts are on Dave's side, and he's gonna probably get his hours restored. But we have gone through so much garbage to get to this point. We were promised restoration, and then we were told that restoration wasn't given to him, and we weren't really even given any reason why. The hours were cut, but we were told that, you know, based on what everybody else is getting, this is what Dave's gonna get now. But there's no like medical reason for it. Dave's never gonna change. His situation is never gonna change. He was born with cerebral palsy. From my perspective, I got a feeling that a lot of the standards that are set for progress in a consumer are based on being able to actually progress. And so I don't know if maybe the Access Center is more looking at the fact that there isn't really much progress for Dave or many more objectives that we can give to him, or if there's actually like another like reason, and that's monetary. And so if it's monetary, why would you guys force everybody into these hearings? This local disputes resolution hearing, it wasn't really, in my mind, it wasn't really even a hearing. We knew right when we walked in the door that it wasn't going to be ruled in Dave's favor. We just got that feeling right when we walked in the door. It wasn't recorded. There was no there's no audio tape of it. And the conclusion that they reached, all of the evidence in the conclusion that they reached is totally debunked in Dave's annual assessment and his person-centered plan. So the reasoning behind docking Dave's hours according to the local disputes resolution doesn't even match his annual assessment and his person-centered plan. And so how did we get to this point, and what can we do to solve this problem? I would have to think that it is a major financial burden on the county and on how many of these local disputes resolutions do we have to go through? How many times does the county have to send a corporate attorney over for Medicaid fair hearings? And is it all just because we have to figure out a way to make up for this budget deficit that the state imposed on us? And so I would think that there's got to be a better way to solve this problem. If we can go to the state and ask them for more money. I mean, this isn't, when Dave's hours were granted to him, the economy was terrible. And now the economy is great, and we're told that we don't have any money. So it doesn't make a whole lot of sense from our perspective. Anyways, thank you for hearing us out, and I hope that we can solve this problem in the future. And if there's anything that we can do from a consumer perspective, we would gladly help whatever we can do. Thank you.
Thank you very much.
Could David, could you spell your last name, or I can get David's?
Do you want to try to spell your last name for the man?
Ho, 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 ho! Ho, 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 ho! Merry Christmas!
Spell your last name.
David Brunnenberg.
Spell it.
BRONNINGBURG.
Perfect.
We'll
Great.
have somebody back in touch with you tomorrow.
Thank you. Thank you very much.
Thank you very much. Is there anyone else from the public that would like to address this body? All right, seeing no one else, we'll move on to item number 4, which is approval of the minutes of the board meeting held November 21. Motion by Flynn, supported by Kraft. Any discussion? All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is approval of standing committee meeting minutes and the recommendations. The Personnel Committee dated December 1 of 2017. All right, motion to approve the minutes from December 1's meeting. Any discussion? All in favor signify by saying aye.
Aye.
Opposed? And next is Recipient Rights Advisory Committee minutes dated December 7. Motion by Flynn, supported by Brown. Any questions or comments? All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is item 6, and we have letters A through H. Under this, many of these came from...
Madam Chair, were these already
No, that meeting,
personnel?
A through E is from the personnel. That have already been discussed, yes.
I make a motion to approve A, B, C, D, E.
Support.
All right, motion by Flynn, support by Bush. Any comments, Lou?
I'm not hearing what the motion is.
Motion is to approve 6A through
E.
E.
Through E,
Through E. Those were all discussed at the Personnel Committee meeting.
thank you.
All right, all in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is item 6F, approval for the modification of the fiscal year 16-18 specialty services contract between Innovative Adult Foster Care, Inc. and Macomb County Community Mental Health.
Christina, do you want to come up to the mic and explain the actions for these next 3 items? Or at least the next 2 items, please?
Innovative Adult Foster Care is a provider who does residential services and CLS and respite services for us. And we had previously discussed one of the homes at one of our other board meetings, and the question was raised about the status of the current home that's on this board action request. What had occurred was we had moved some folks out of the home. We did a residential audit this summer, and the audit scores are included in your packet. Because of the scores of the audit and the conditions of the home, business management made the recommendation to move the 4 individuals out of the home into another home per their choice through a process where they have a visit and they get to choose the home that they're going to, and then to terminate the residential services in this contract. They would sustain the CLS and respite portion of their contract. This would remove 2 of the codes, which allows them to provide adult residential services. I can give you more detail, but that is kind of the basic overview if you have other questions.
Okay, we need a motion.
I move to approve. Move to approve.
Motion by Flynn,
Support.
support by Brown. All right, any further questions? Seeing none, all in favor of approving the contract signify by saying aye.
Aye.
Opposed? Motion carries.
Thank you.
Next is item G, request to approve the release of the following RFPs: autism services, occupational therapy, physical therapy, speech therapy, recreational therapy, and residential property.
I move to approve them, or is somebody going to talk about it?
I can just give you kind of a brief of why
Sure.
we're asking for that. So we're
Thank you.
asking you to approve us to do the release of the RFPs, so you don't have the RFPs in this packet. We would present those to you next time. But these are service lines that we are seeing a lack of providers. So, for autism, as you know, the age expanded. So we have a few number of autism providers, and OT-PT speech and rec therapy are service lines that we haven't historically had a large network, and we are seeing the need to add to that service line. The residential property goes in line with the residential RFP that we did this year. So now that we have the providers that we want to select and offer contracts to, which again we'll bring to you next month, we're going to need the properties to build those arrangements. So we want permission to do these RFPs so that we can expand the network to have ample services. Additionally, we had a lot of providers come out and show interest in these service lines. And so if there were 1 or 2, we perhaps would have done a pre-delegation audit and reviewed them. But because so many have come to us with all those different ones, we're feeling like we really need to do the procurement process and do an RFP and make sure that we bring someone on board that we're all confident in.
Thank you. All right, we have a motion by Flynn. Support by Nagovan. Any further questions? All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is item number 6H, redaction of addresses and parcel numbers. This is, thank you for the explanation. And this is, there's a letter attached from Aaron Thomas of Corporation Counsel. You want to?
Sure. You know, the board has discussed over the last few months our change in practice in redaction of the addresses and the names of the group homes when we prepare a lease before the board. And there's been a little bit of mixed opinion on that. I asked Pat Jens to give us a legal opinion. And, you know, Pat, if you want to embellish it, you're welcome to do that as well, too. And then I also asked Pat to collaborate with Aaron Thomas, who reviews all of the leases ahead of time, and to also get his opinion. Now, he didn't write it up as a formal opinion, given the time constraints that we had, but Pat did confer with him, and then she wrote up a summation that's in your packet relative to the legal aspects. I'll let Pat, you want to embellish that a little bit further, that there is no legal obligation on behalf of the board or the community mental health program to publish the addresses and the names of the group homes. But I'll let Pat.
I think in our internal discussions, we believed that there was no impediment, and that's pretty much what Aaron Thomas from Corporation Counsel confirmed, that there's no legal impediment. It's up to the board. We did indicate to him that there was some issue with regard to whether this is something we should change because we've been doing it this way for so many years, decades. He did not comment on that, but he did say it's up to the board whether to redact or not.
But the point is, there is no legal requirement for the. There's no legal opposition that would.
There's no legal reason to keep it. There's no legal reason to take it out.
Okay.
It's up to the board.
Commissioner Flynn.
Could I have the floor?
Yes, and then Birdie.
Is it all right with you, our executive director? I mean, which way do you want to go?
Well, my personal professional opinion is that we started the ball in motion here relative to increase privacy and security for our consumers. And if our consumers don't necessarily need to, or the public at large doesn't need to know where all our group homes are, then let's practice that way. Even though historically we've never had any challenges or any threats to our consumers, we felt it was just a movement towards privacy. Our legacy practices were always to post those. So my opinion is that if there's no harm, no foul, and we can offer them a little bit more privacy, then I would be in favor of going that direction. But
Then I'll make a motion to approve this.
All right, motion by Flynn, supported by Bush to.
This one won't directly answer the question.
Okay.
Mine doesn't.
And I'll get you, you're next. But I just we have a motion by Flynn, supported by Bush, and that is to continue redacting the information. Is that your intent?
Yes.
Okay. Commissioner Birdie.
There's no legal purpose, and I never suggested that there was any legal requirement to post the addresses. What I said was that it was good policy to post the addresses because they relate to group homes in neighborhoods. And if you were any part of the process from the 70s that got us to this point with group homes, you would know how important it is for a neighborhood to know that a group home is being placed in their vicinity. And all of a sudden, we're now publishing group home contracts without addresses. It looks like we're trying to hide something. And frankly, I don't think that we are, but it certainly begins to look like we don't want a neighborhood to know that a CMH group home is being reinstituted in their neighborhood. And that's poor policy, and frankly, it pierces the veil of transparency that we brag about. What we say is what we do in the full noonday sun for everyone to see. And all of a sudden, we're going to redact addresses of group homes in neighborhoods. You've got to be kidding me. This is absolutely a terrible decision. And what I said at the last meeting is, I will not vote to approve a single contract for a group home that has a redacted address. I will not participate in any action like that, and frankly, I'm embarrassed, John, that you would even consider it a policy. And I will tell you frankly, if a problem occurs, staff will not have the heat. You may have a little bit, but we'll get it all. And frankly, that's where it belongs. It's the heat that we would deserve by redacting addresses on group home renewals. I can't believe that you would want to do this. And I will say clearly, I will never vote for a single one of these because it is poor policy and it does not represent our best effort. And it's a serious error in judgment.
Okay,
and if
thank
you
you.
read the Corporation Counsel's opinion, he says it's a board policy. I can't believe that we would pass a policy not to publish addresses of group homes in neighborhoods. That is ridiculous.
All right, thank you. Commissioner Connell, did you want to speak? Anyone else? All right, we have a motion. All in favor signify by saying aye. Aye. Opposed?
No.
No. But, how many noes do we have? 1, 2, 3, 4? All right, motion carries.
Madam Chair, I just want to point out that the computer system don't have it, we can push the call.
I see that, it's not coming up. So I'll try to look around. Please raise your hand if you want to speak on some of the issues. All right, next is item number 7. We have lease agreements A, B, C. Do we want to take them together or separately? These have not been discussed. These are from the meeting that was canceled because of the weather.
Together, don't you
Is
think?
that a motion to approve lease A, B, and C? Are you
Yes.
making that motion? All right. Is there support? Support by Kraft. Any questions, comments? All in favor signify by saying aye.
Aye.
Opposed?
No? On all three? All three at one time?
Yes.
No.
Okay. All right, next is item 7D, contract extension for Great Lakes Center for Autism, fiscal year 17 and 18. Would you like an explanation first? All right.
This is a provider that we've been contracted with for some time, and they requested to only do a one-year contract last year. And so this time we had to do a brief extension on that contract, and this is just to extend it. We have one person served at that organization.
All right. Motion by Kraft to approve, support by Flynn. All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Thank you again. Next, item to receive and file from the meeting of December 13. Review of the Macomb County Community Mental Health Interim Financial Status Report.
Comment?
You want-
Sure, we'll run through the interim report. Cynthia Mack is going to do that in her usual fashion, bring the board up to speed. We actually submitted this report to the department on time. It's the interim report. Cynthia will explain, what the report is really about. It's about last year. She'll explain that, and also in her usual fashion, bring us up to speed on where we are financially on the Medicaid, Healthy Michigan, and general fund dollars.
Great, thank you. As John mentioned at the December 13th meeting that was postponed or canceled due to weather, I was going to report out what I will today as far as our interim FSR. We submitted that to the state in November, and keep in mind that since November, we have continued to receive in expenses, and we'll be reporting out our final FSR in February, which I would expect to report out at our March meeting, program and budget. So with that in mind, it's in the normal fashion again that we've been reviewing for about the last year or so. If I can bring your attention to the sheet that you have in front of you that breaks out both our Medicaid and our Healthy Michigan numbers separately. What I'd like to focus on is for the fiscal year 16-17 column. If you're looking at Medicaid, we started our year at a $15 million FSR. As of November, our revenue that we realized for CMH, for mental health, was $145 million. We also include in that our SUD figures, and for that we had about a $3.3 million revenue amount. We also had to do an abatement of funds, which I'll explain that a little bit later in the report. We had an abatement of funds of about $9 million. So in total, that brought our revenue for Medicaid to $158 million. Our CMH Medicaid expenses came in at $165.7 million. Again, combining with our substance abuse, they had expenses of $3.1 million for a total expense of $168.9 million. As you can see, that resulted in a deficit of $10.9 million. Now, we cannot show a Medicaid deficit, so that's where our abatement of funds comes to play. In order to not show that deficit in Medicaid, we had to abate some of our funds from the ISF. So we draw down funds from our ISF, and that turns into revenue. Therefore, that's where you see that $9 million up above. We also had a redirect. We were able to move some funds over from our Healthy Michigan, along with some autism dollars. That amount was roughly $6 million. So taking all of those numbers into consideration, we had to draw down from our ISF roughly $4.8 million. So where we started at $15 million in our ISF, drawing that down, along with the abatement of the $9 million, it drew our ISF down to just a little over $1 million. Now, from the funding that we received for the $5 million, we do add that onto the books, to the ISF. That's what it was slotted for. So that brings our ISF for Medicaid to be $6 million. Any questions on that so far?
Could you say again what 7.5, what the required 7.5 is on the budget?
I'm sorry?
How many million is reserve of 7.5?
As far as what we're required to cover ISF, which is still up for debate. I think at the last few meetings, we've been talking about the question if that's really a requirement or not. So it's the 7.5 of our combined revenue.
Which is
12.6 million.
Correct. Still staying on Medicaid, what we could do is look at the column with 17, 18, our projections. Again, we have not received any updates in that column. We haven't touched our budget information. So at this time of this report, this is strictly what you've seen all along for the last few reports. Again, in March, we'll have an update to our revenue expectations going into the new year and be able to see where we're going for the new fiscal year. Keeping that in mind, just knowing that the numbers are what we projected all along, we are still looking to end 17-18, bringing up our ISF to roughly $10.7 million. On the Healthy Michigan side, we started 16-17 with an ISF balance of about $338,000. We were able to have a carry forward from 15-16 of $7.8 million. Our additional revenue that came in for Healthy Michigan was $9.9, combined with substance abuse of $6.7, resulting in total revenue for Healthy Michigan at $24.6 million. Our expenses on Healthy Michigan, $12.1 million, Substance abuse, 6.1 million, for a total of 18.2, resulting in a surplus 6.3 million. Of that redirect that we did for the Medicaid, the portion that came out of Healthy Michigan was roughly 5.4 million, leaving us still a surplus of 916,000 in Healthy Michigan. Adding that to the original 338,000, our ending ISF is projected at 1.2 million for Healthy Michigan. Same thing stands moving into 17-18. We've not adjusted the budget numbers at this point. We've not adjusted our revenue numbers. We will have new projections on that come March. As it stands right now, 17-18, we are projected to end the year with a $1.4 million ISF. Moving on to general fund. For fiscal year 16-17,
Can I interrupt? Could you do the Medicaid and Healthy Michigan combined?
sure. For 16-17, combining the ISF balance, we started it out at 15.4 million. Our combined revenue, 7.8 million. That was the carry forward from Healthy Michigan. The additional revenue, the new revenue for the year, was 155.4 combined. Substance abuse combined 10.1, resulting in total revenue 173.4 million for 16-17. CMH expenses 177.9, substance abuse 9.3, for a total of 187.2. Total combined, resulting in a deficit of 13.7 million. We did have some redirected funds of 640,000, resulting in a deficit drawing down our ISF by 3.9 million combined. So when you take our unadjusted ending ISF balance at 11.4, plus the abatement that we did for Medicaid of the 9 million, our final ending ISF balance, Medicaid and Healthy Michigan combined, we're looking at 2.3. That's again before the $5 million that we received in that grant of general fund for Medicaid. So with that, our revised final ending ISF balance, we're looking at 7.3 million. Looking at starting 17-18 with that 7.3, again, keeping our revenue as what we've had for the last few reports, we're at 159.3. Substance abuse 9.6, for a total of 168.9. Our combined expenses between Medicaid and Healthy Michigan, 154.4. Substance abuse 9.6, for a total of 164. Leaving us there, we're looking for a projected surplus of 4.9 million. Adjusting that to the beginning ISF of 7.3, we are looking at ending 17-18 with a 12.2 combined ISF. If I could just comment on that, again, that's with the numbers that we've had as for revenue and what we've budgeted and was approved by the county this year. Come March, we will have updated revenue figures and we will be looking at adjusted expenses as well.
I have a question. If we were to receive no more income for whatever reason, no more funding, and we wanted to use up the funds that we had available, how much would we have available to use for Medicaid spending and how much for Healthy Michigan spending?
I'm sorry, I'm not sure if I'm following as far as the expenses.
With the money that we have a balance of 12,245,000, right? ISF?
For 17-18?
Mm-hmm. At the end, yeah, protected, right. So then if at the end of that period, if say we decide we, for whatever reason, had no more funding, how much would we be able to spend for Medicaid, to finish, spend the rest of our Medicaid dollars and spend the rest of our Healthy Michigan? How much of each would we have?
Well, that's, I think, where the debate still is out as far as what we need in our ISF. Whether the contract is saying that we still need that 7.5, which I think we're under the belief that we want to have it, we have to have that, as that's part of our risk management, which we'll be getting to next on the agenda. But that's not necessarily a guarantee that we need to have that, is what we've been hearing from the state.
Okay, let's say we don't need it. It just, excuse me, I'm asking a question. If we, I guess what I'm getting at is, can we use it all for one or the other or both?
Depending on the interpretation of the contract and that we don't have to have a fully funded ISF, yes. But again, on the other side of that, we need to have some type of risk management strategy, which in our case, it's this ISF funding.
Sure, okay. You have a question?
Personally, I don't agree with that response. The ISF that she's showing has the shift from Healthy Michigan. So if you were to apply the ISF, you can't apply the shift from Healthy Michigan unless you want to do 5 years at Leavenworth.
Okay, that's the
And
issue.
she did not say that.
And that's the issue that we can, so rather than, let's move on then to, does anyone else have any questions about what's been presented so far?
You know, I just want to comment,
Yep.
I agree, you know, with Lou, and that's what's at the, you know, point of discussion here. Historically, the department did not let us commingle, if you will,
Right.
Healthy Michigan and Medicaid dollars into your risk reserve. Now they let you do that. They, you know, it's kind of like funny that they let you use Medicaid and Healthy Michigan and commingle them in your risk management strategy and your risk reserve. When it comes to actually using those dollars, even though you shift them over there and put them on a line item to make sure your ISF is sufficient, you can't use Healthy Michigan dollars to cover a Medicaid deficit. You know, and I agree with you. You know, that is not permissible. You can use it in the strategy. You cannot use your Healthy Michigan to offset your expenses if you realize them on Medicaid.
All right, thank you.
Correct?
Yeah.
Going to
Anyone
move
else?
on to GF?
All right, then let's hear the, anything else on this? Then let's move on to the risk management strategy.
We have the general fund.
I'm sorry, yes, you have one more.
So for fiscal year 16-17, our carry forward was 379.8 thousand. We had our revenue at 8.4 million for a grand total of 8.8 million in general fund. Our expenses are projected to come in at 10.3 million, resulting in a $1.4 million deficit. In order to cover that deficit, we have to draw from our local fund balance to cover that. So again, drawing down that full 1.4 million, which again takes us with no carry forward into the new 17-18 fiscal year. For 17-18, our revenue is projected at 8.1 million. Our expenses projected at 7.7 million, looking to get us to a surplus of 419,000 for 17-18.
Okay, Linda?
I have two questions. What is the source, this fund it's called the fund balance, local fund balance? What is that and how much money's in it and how did we have it?
That fund balance has accumulated over many, many years, roughly I believe 25 years, from various interests on funds that we've had. Basically how things are running now, it would take years again to basically refill
Replenish
that.
it.
So we have that. I don't have the exact figure with me. I could get that back to you as far as what we have with that local fund balance sitting from the county. So we would be drawing down the funds from them.
Okay, and then my other question is, could, at some point, maybe at the next meeting or in February, a report on how we go from 10.3 spending in 16-17 to 7.7 in 17-18. What kind of cuts are involved in that and where that comes from to get that new expense estimate?
I can touch on that a little, as far as, again, we can get more specific. With basically the strategy that we've been doing, the strategic planning within, as far as where we can save in our general fund, various programs, organizational changes that are hitting our general fund, spend downs, things like that. That's where we took a look at by programs to see where we could reduce expenses.
So I'd probably like to have more information at another time on what that looks like, how that translates to the consumer, you know, where the cut affects somebody.
Sure.
Okay, thanks.
Any other questions on this? All right. Thank you. Then do we need a motion to receive and file? Okay. So if we could have a motion to receive and file the interim financial status report.
Make a motion to receive and file.
Motion by Nagovan. Support by O'Connell.
Support.
All in favor signify by saying aye.
Aye.
Opposed, motion carries. Next is our risk management strategy review.
Thank you, Madam Chairman. If I can run through this risk management strategy with you, this is part of the contract that the PHP and the GF contract both we have with the department relative to establishing a risk management protection strategy for this fiscal year. We delivered that on December 1st. So first I'm going to run through the Medicaid side of it, and then I'm going to run through the general fund one. The one we need to pay attention to. There's a lot of monies moving around right now, and I'm going to speak to a little bit later in my director's report. But what we need to be attending to here is what the board has been familiar with, and we've talked about time and time again for the last many months, is that we've always been fully funded on our internal services fund for the last 6, 7, 8 years. This is the first year that we're not fully funded in our ISF. So when you look at the narrative that we put together on page 1 of the risk management strategy, it's really a bifurcated process on how we're going to go about managing our risk. One is through the established ISF, which Cynthia indicated was $7.2 million. She just told you that's how much we have is $7.2 million. What we actually need is 12.6. And so how do we mitigate our financial risk of the $5 million or thereabouts? And so the first thing that we do is we establish the Medicaid ISF, and the second one is that we do risk mitigation measures. And so we do know what, based on our 2014 actuarial analysis where we hired Milliman consultants to help us with what our risk may potentially be on the Medicaid side. We know from 2014, and we're going to come back to the board in 2018 here next month in February perhaps, and ask for another analysis on what our potential risk is. But we also know what it is relative to the 7.5% of the revenue that we need to protect in the way of our budget. So we're fully funded. In this little bit of history here, we went and created some history for not only the department but for the board too. In 2005-06, we never really had an ISF, and then we started to establish one. And then the last few years, we've been fully funded in around $15 million. You turn to page 2, we actually need, and our maximum allowed is 7.5%, which is $12.6 million in the ISF. And so that's a combined ISF using Medicaid dollars, substance use disorder dollars, Healthy Michigan Plan dollars, and also the general fund grant of the $5 million that the legislature appropriated to us. That next paragraph really speaks to what Cynthia has already talked about, what we currently have in actual cold hard cash in the way of a risk reserve or insurance. You get into number 2 there on page 2, it's assessment of financial risk and correlated risk mitigation measures. So this first section here, A, is really it's kind of, we wrote that and threw it back in the face of the department, as politely and professionally as we could, is because that the state went through Medicaid rebase. I wanted to hear them to hear that again, and we wanted to make sure that it was on record that as a product of the rebase, where they removed the utilization factor from the funding formula, we actually lost an awful lot of revenue relative to how we do our operations. Historically, and you've heard me say before, that prior utilization of services and costs are a predictor of future utilization of services and costs. That's not the rules of engagement anymore. Just go ahead. Prior utilization doesn't mean, you know, that's going to afford your funds in the future, your services in the future. So what we had is the removal of the utilization funding formula, and hundreds, you know, into the thousands, you know, I'll go up as many maybe as 2,000 consumers, those with intellectual developmental disabilities, they were receiving community living support services to control their own lives, to be without the influence of control, to live in the least restrictive settings, as you heard earlier tonight, to be fully participating in one's community. You know, that is what we've been challenged with here on correcting for our CLS services, and we've been dealing with that now for 18 months. At one time, we had 950 consumers with self-determined lives, self-determination and choice of services. So what we've subsequently done is we've engaged in pretty aggressive, progressive utilization practices to bring our CLS costs down, and so that's had a negative impact on a number of our consumers. Most notable was the reduction of CLS services to consumers who needed supervision overnight. And so we removed those services. You know, there's not attainment of skill, as you heard earlier today, tonight, there's not an attainment of skill, but there's a maintenance of effort. You know, if we can make good cause to be able to have someone continue to reside in their community and provide them with health and safety during the middle of the night, then all the more let's do that. We're not funded to be able to continue to do that. So the number one, or one of the major things that we're going to continue to focus on in our risk mitigation, we have to pick up $5 million. And I can't put a number on this figure because it's medically necessary. If we have more consumers come in that need services and they're absolutely medically necessary, then we're going to deliver the service. But through progressive, and I'll use that word, progressive utilization management practices, where we can reduce those services and deliver our services more in line with where the department wants us to do those, then that's what we're going to do. And so what you will see is part of the risk mitigation with no dollar amount attached to it, but the intent to be able to control some of our costs is increased utilization practices on the CLS side. That's the number one thing. Number two is, this is your mitigation. How do we pick up $5 million? The other, number two, is the utilization management of acute psychiatric inpatient hospitalization trends. We spend about $14 million a year on acute psych. 2 years ago it was 14.1. Last year, or 3 years ago, it was 14.1. Last year it was 14.1, and this year it's like going up to 14.3. There's probably a lot of reasons for that, but if we're going to be successful, we need to pick up dollars on containing our utilization costs on the acute psychiatric inpatient services. So there's a number, I think I put 10, 11 different strategies on how to do that. We have to increase crisis stabilization services for adult. We have to be progressive in redirecting people who either on the front door or on the back door to offer up crisis stabilization services. We have a program in place, crisis residential services, assertive community treatment. We have programs available. We need to make sure that we get the right people into the programs. Increased supervisory training of those utilization management staff so they have more confidence when someone's presenting with, you know, quasi-suicidal ideation, that the staff can actually deny the payment and feel comfortable about doing that. That's not an easy thing to do, but that's their job. It's my understanding through some of my staff that they're pursuing an electronic utilization platform that may be out there that Detroit Wayne is using. Maybe we might use it at some point in time. It would cost us some money, but the return on investment might be favorable. Increased use of crisis alternatives as a step down once somebody's already been in an acute psych hospital. Continued use of the UBHC and improve on that program and the capacity to control for our acute inpatient costs. Increase peer support services delivered on the acute psych units. Collaboration with hospital providers. You know, we have staff that actually are in the emergency room at Henry Ford on 19 Mile Road trying to prevent consumers from being admitted to acute psych facilities. And continued collaboration not only on the behavioral health side on our side, but also on the Medicaid health plan side. So we have to pick up, you know, a considerable amount of revenue on the Medicaid side through controlling our acute inpatient cost. number C here, and again, here's how we're mitigating our risk, that our provider panel reimbursement rates, I'm not proud to sit here and say that, or pleased with it, but they're still frozen at 2015. Do our providers need more money? Yes, they do. Do our caseworkers, our supports coordinators, our skill builders, our residential providers, do they need more money? They absolutely do. We have to have the money to be able to improve their rates. In general, on number D here, in general, we're operating approximately 20% of all the Medicaid services in Macomb County as employees of the county proper. About 80% of it's contracted out. We have to be ardent here. If you skip down to paragraph 2D, we need to continue to work on improving triple aim, cost, quality, and outcomes. And that's not going to go away. You have to have cost, you have to have quality, you have to have quality and outcomes to be able to support your cost. So the ongoing strategic planning that we've been engaged in for some time, and I've brought to the board before, where we do things well and we do things that have good outcomes, then we're going to continue to build those programs. One of those is children's services. I believe that we provide better, comprehensive services to children, to very complex families and children, than anybody else out there. And we need to start, having a database. We need to have a dashboard so the board can see that. We've had some of those discussions, matter of fact, early this morning. How do we create a dashboard to show the board and the community all of the things that we do relative to supporting children? Some programs we don't do really well. And when that's the case, and we can find a vendor who's better positioned to deliver those services, then we need to move those services to that vendor. And that's not an easy task sometimes when you're talking to the union. So I've summarized that in, being fair. I think the board will be fair, I'll be fair, the administration will be fair. When we can direct operate services and provide that cost, quality, and outcome and achieve triple aim, then we'll deliver it. And where we have to outsource it or contract those services out to another vendor, we're going to do that. That's a big deal. Those are the four ways that we're going to be able to tackle the majority of the Medicaid revenue to expense deficit that, it's not a Medicaid revenue to expense deficit because we're really showing a positive surplus of $4 million. But that's the risk mitigation. If we get it wrong, where do we come up with the $5 million? And so then if you move to the second part of this, it's the general fund contract. So it's the same type of thing, what our expenses are and what our deficit is and the risk mitigation for that. It's a little bit different taste here. We have a number of consumers who are on Medicaid, and when they have to re-enroll in Medicaid, if they don't get their application and re-enroll on time, then their costs go to general fund. And so we have to, throughout the entire network with all of our caseworkers and our contracted caseworkers and supports coordinators, make sure that their number one job, even though they went to school to be a social worker and to be clinically involved with their consumers, their number one job as a social worker is to make sure that consumer has Medicaid and don't let the Medicaid application lapse. Well, they don't think that's their number one job. It is. In this world, it is. And so it's a paradigm where we need to make sure that anybody who has Medicaid keeps Medicaid. So that's the number one thing. The other thing is, it's, right down the same road, is the spend down. The spend down issue has never gone away. So if a consumer doesn't meet their spend down and they show up at the door, at the outpatient clinic and say, I'm depressed, I need you to see me today, you have to say, I'm sorry, you haven't met your spend down yet. And that's a difficult situation for our staff to be in. But that's the reality of how we work. If they're emergent and they need to be sent over to an emergency room, then they do. If they need to get their medicine, they haven't met their spend down, we don't have the general fund dollars. And so it's not a time to hit the panic button. But the general fund dollars are not going to be readily available, and they haven't been readily available. And we need to make sure that we educate our staff and the consumers relative to the rules of Medicaid. Everybody who we can get on Medicaid needs to be on Medicaid. That's the focus for the entire system. Further on item C, there's a lot of consumers that are coming through for acute psych. I just cut and pasted all of item C from the Medicaid side, how we can control our acute inpatient costs. And we need the UBHC to kick up its heels a little bit more and to be able to help out on the redirection of the acute psych problem. And anything that we have left over where we don't meet our deficit, and then we have an unrestricted account, and we'll pull those dollars out of the unrestricted account. So I'm feeling favorable about the risk management strategy. I do believe our financial situation is much better than it was a year ago sitting here. There are a couple caveats to that, and I'm going to bring them up in a little bit, but not right now. That's the risk management strategy. Any questions?
I have a question. This was sent to the state, and do they comment on it? Do they approve it or not approve it, or make comments?
They'll eventually get around to reading it, and if they want clarification or addition or subtraction to it, they'll let us know. Yeah. You didn't read anything yet, but they will.
Oh, you will get some type of a response?
Yep.
Okay. All right. Any other comments any questions from the commissioners? All right. We need a motion. Motion by Flynn to receive and file. Support by Brown. All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next, we have 9C, Medicare General Compliance and Medicaid Fraud, Waste and Abuse Training, Medicaid Corporate Compliance Training.
I'm going to invite Kimberly Cope up. As you all know, Kimberly's our policy administrator and corporate compliance officer. And this is a requirement of Medicaid and Medicare. And Kimberly's going to walk us through your requirements to have a refresher or be debriefed on the requirements that you have as board members for corporate compliance issues. Kimberly?
So in your packet are the training slides that are provided to our staff for your review. We're not going to go through every slide, so that will cut down the time, right? I just want to highlight a few things that are in there, and then I can take some questions if you have any questions. I want you to know that the compliance plan that you're responsible for is found in policy 1-001. So if you ever are wondering about what's involved in compliance and what your responsibilities are and what the requirements are, you can always go to that policy. It's on the CMH website, and it's always available electronically and in hard copy if you'd like it. We can do that too. So managed care organizations are required by the federal government to have compliance programs, and we fall in that category as a prepaid inpatient health plan. And so our purpose with the compliance program is basically to ensure that funds are not diverted from our consumers and directed to, illegal or inappropriate spending, but we try to ensure that the funds that should be diverted to the consumers are appropriately diverted to the consumers and not spent on inappropriate, types of billing or any items of that nature. And so it's a condition of receiving payment from the state and the federal government that we have a compliance program. Medicaid is the payer of last resort, as I'm sure you are all aware. And so that means that all other liable payers should pay before Medicaid pays. That includes Medicare. And as a participant in my HealthLink, the ICOs, the integrated care organizations, have delegated compliance to us through that program. And so the Medicare Managed Care Manual and the federal rules require boards to be trained on the Medicare fraud, waste, and abuse training that you see in your packet. That comes directly from the Centers for Medicare and Medicaid Services. And so that's verbatim the trainings that everybody's required to take. The second training that you have in there is our corporate compliance training, which also includes HIPAA training, and that's for the Medicaid component, and that is tailored to our specific compliance plan. And it can change as we change and as we develop the plan. So there are 7 elements of an effective compliance program, and you can find those, of course, in the compliance plan and also in your training slides.
Some highlights are, we have to have the written policies and procedures, a compliance officer, which currently is myself. We have to conduct effective training and education, and so within 90 days of hire, all employees are required to take these compliance trainings, both the Medicare and the Medicaid trainings. And then annually, they're required to take refreshers. And they actually get quizzes at the end, and they have to pass the quizzes. So you guys don't have a quiz tonight. But if you have any questions, I'm more than happy to answer them. We have to have effective lines of communication, and so there's several ways that we do that. We have a specific compliance hotline phone number that anybody who has a concern can call and report to us. We have an email address that anybody can use to report a concern. We also have, our direct emails that they can go ahead and email us directly. And then on the website, there's actually a form that anybody can fill out, and it can be anonymous if they don't want, to be recognized, but they would like to report something. And they can fill it out and they can send it to us, and we can go ahead and take a look at what their concern is. We received almost 300 concerns last year. So, and almost half of those turned into something that required some bit of an investigation. So I'm happy to say that people are taking advantage of the compliance reporting, and I think that they're concerned. And it's nice to see that, because it's one of the indicators that our program is effective, because people are wanting to be participating and ensure that the consumers are receiving the services that they should be receiving, and that the funds aren't being diverted, in a way that they shouldn't be, to enrich, a provider or somebody else, instead of actually having services provided to the consumers. We also do internal monitoring and auditing. So we'll go ahead and, we do that with the express audit, but we also can do focused audits. If we see a concern with a provider, we can go ahead and we can audit, a specific concern, or we can do a more expanded audit. So we'll go ahead and look at that also. And then we try and enforce the standards through well-publicized disciplinary guidelines, which are in policy. And so everybody has access to the policies, and they're distributed yearly. There's a reminder that everybody is to be familiar with the policies, which I understand is fairly difficult because we have more than 200 policies. But the disciplinary one, is one that they should be familiar with. So one of the other things that we try and do is we try and promptly respond to any concerns. And so within a couple weeks of getting the concern, if we need to, we'll open a case. And then all this interplays with the Office of the Inspector General. Michigan has its own office, and then the federal government has its office also. And so Macomb County Community Mental Health reports all suspected instances of fraud immediately to the Office of the Inspector General. That's their requirement. And then monthly we report on any suspected concerns regarding waste and abuse. And so they're aware of any of those issues, and if they have concerns, they can follow up with us. And it's an affirmative duty of all of the staff to report concerns. And so, just in order to ensure that funds aren't being diverted improperly, and, that if there's inappropriate documentation, that we can look at it. If there's improper billing, that we can go ahead and look at that too. So, and if you have any questions about what we do or how we do it, I'm more than happy to answer any of those.
Thank you. Are there any questions?
How many people, and you drew the chair, how many people on your staff?
I have 3 full-time and 2 part-time employees.
And you get all this done?
We try.
Linda?
Thank you.
Constitutes our training.
It does. I'll be back to train again in a few months on more specific requirements for the board, but this is your general training. So in order to familiarize you with what compliance is.
So if we have, as we're going along, if we have any questions or run into things, we should give that to you ahead of time so that the next training would be
Sure.
more
Yep.
to what we would like
Yeah, that
or
would
need.
be great.
Sure. Brian?
You're not gonna test us?
I'm not going to test you
Well, that
because
takes all the fun out of this.
I'm sure that you'll pass.
Because I got the answers that came with it.
Right? I know, I saw
Well,
that.
test us. Thank you.
All right, seeing no other comments at this time, later we'll go, oh, I have a question, but,
Well, email me.
yes, we'll
All
do.
right,
Thank
thank
you
you.
very much. We, motion to receive and file is in order.
Motion.
Motion by Birdie, support by Nagovan. All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Thank you. Next is the Macomb County Community Mental Health Marketing Communications Update, the long-awaited update.
I'm going to invite our marketing agent, Kevin, up to the podium here. Kevin's going to run through it with us.
Good evening. My name is Kevin Sadich. I've been the acting communications coordinator here since last December. It's been my pleasure to be here and serve the county. This will be a summary of activities since my last report to this body in May.
Before you begin, we all have a folder here.
Yes.
All right, thank you.
Now, when I press this, you can see on your screens what I'm doing.
All right.
Okay, just want to make sure I know what's going on here. Okay, so since the last update to the board here, we've had increased engagement of Macomb County Community Mental Health with the County of Macomb. This has been accomplished through a variety of media relations, marketing, digital communications in the form of press releases, media mentions, marketing, and digital collateral, including social media, the intranet, and our website. We've had 10 press releases issued since the last report in May. You have hard copies here, and for the people in attendance, I have also a folder of hard copies of our press releases. The press releases have included information on various initiatives such as participation in Macomb County events, milestones such as CARF and Crossroads certification, and events such as the Opioid Forum and the Recovery Rally, with the purpose of informing the community to better engage them about our activities here. The next slide here just shows links to the press releases. You have hard copies. All of the press releases are available on our website at all times and also on the county website. We've also developed a news page on our CMH website so we can also highlight our press releases directly. Earned media coverage has included 10 pieces of media coverage with approximately 52,000 estimated coverage views, which basically means it was viewed about 52,000 times. This does not include the number of views we've had on television coverage, which I'll get to in the next slide. These have been various stories, positive stories about our crisis line, what we're doing here to combat the opioid epidemic, and some other media inquiries. The media mentions here, again, I have links to them. I can make them available to the board if you'd like. These have appeared in C&G, Macomb Daily, Detroit News, and Channel 20. Here we have just some screenshots of some of the media stories that we've had. At the top left is from a television show called My Healthy Mind, which appears Sundays on Channel 20. Some op-eds that I helped write and place, and some other various media appearances. Marketing support has included support advice to the Office of Substance Abuse on the Recovery Rally, which has included media interaction and development of some marketing material for them. Development of business cards and posters for our crisis center. The presentation says printing pending. That is printed, and we're in the process of distributing those to the community. The development of a half-page flyer for Macomb County Community Mental Health, which is also in the process of being distributed to the community. Development of anti-stigma materials for digital communications. Development of suicide awareness materials. Request for proposal support, and development of the format for the 2017-18 strategic plan. These are a screenshot of some of the marketing materials that developed, and I've also included hard copies as well for you to take a look at. Social media, well, this April, we established our social media presence with Facebook. Since then, we've had increased engagement with that. Our services, our organizational milestones, current issues, as well as increased opportunities to provide information about our crisis line and anti-stigma activities. Our social media has increased 375% from May, when we had 145 subscribers. Now we have 728 as of today. Our views through our Facebook presence have included 28,000 views of our posted information. So to put that in perspective, our earned media was about 52,000 views. Facebook alone is 28,000, so that's, I'll get to it a little later, but that's about 33% of our total media interaction in Macomb County and the region. Our social media has included information on anti-stigma, anti-suicide information, coverage of mental illness awareness week, crisis line, shared information from organizations such as NAMI and SAMHSA, events such as our opioid forum and recovery rally, and highlighting our press releases. This chart just shows a gradual increase, consistent increase in our Facebook followers.
How do we get, through the chair, Kevin, how do we become friends of you on Facebook?
So the main way we get followers is we actually develop promotions on our Facebook page. We ask people that are members to tell your friends, and most of the views that we've gotten on our posts on Facebook have been through current followers sharing it with people that they're connected on Facebook, and then they'll share it.
So can we just automatically be on your Facebook?
You can follow it. You can click the follow button, and you're immediately engaged with our Facebook activities, and you can share it with your friends, and that's our main.
Mental health.
Yeah, community mental health. Yes, ma'am. Another aspect of our digital communication support here has been development of our
Thank you.
CMH in the news page on our website, so we can highlight our press releases. We've added our Facebook news feed to our homepage, and we've posted various information such as updates to the UBHC information, RFPs, and other requested information. Our web engagement is about 1,000 members a month. So from November, or from May to November, we've had about 5,000 visitors to our web page. It's a pretty consistent number over time. Our intranet support has included information, human resources type of information, such as job openings, health fairs, organizational announcements, and quality of life programs. And those are some screenshots of some posts we've put up. So this summarizes our total media reach. We've had 86,000 media impressions, 28,000 of those have been Facebook, 52,000 have been earned media, and then about 5,400 through our internet and intranet engagement. To me, it shows the importance of our social media and how we can engage the community directly rather than always depending on media, which is also very important too. So overall results, increased awareness of the community with Macomb County Community Mental Health Programs and Services, increased general awareness of our challenges and accomplishments, increased anti-stigma promotion, significant increase of almost 400% in our Facebook engagement, and consistent visits to our website. Again, it's been my pleasure to serve Macomb County Community Mental Health. If there's any questions, I'd be glad to answer them now or later at your convenience.
Thank you.
Thank you.
I do have one question. Are there any goal for how many on Facebook, how many followers on Facebook that we would like to have?
I'd like to reach 1,000 by the first 12 months.
Okay.
So that's my goal, and we're on schedule.
We're
to
on
do that.
track for that, yeah.
Thank you.
Linda?
It appears that sometimes it's just a picture of a document, a picture of something, rather than an actual document put in on Facebook. Is that the case? Sometimes you just take, which the quality is.
Yeah, well, rather than putting whole documents on, which can be done, it's oftentimes more effective by putting an image.
I don't mean that, it's a picture of words.
Oh,
Sometimes there has been a
yes,
picture
yes.
of words.
Yeah, a lot of the posters that I've created have text in them, rather than writing the text in the post. It makes it easier for people to share it and things like that.
Joan?
Thank you. I think it's wonderful that you've got all these papers here. I consider myself a good reader of the papers, but some of the articles I seem to read in papers are just little spurts. Maybe I'm reading the wrong paper. So this is the Detroit News? Is this what it means?
That's our press release.
That's your press release.
But I'd be glad to
So
provide
you don't know whose paper it went into?
We do. I have a list of links of the actual coverage that we've received, and I can actually email that to you if you'd like. I could provide it to the board if you'd like that too. Direct links to the coverage.
I'd like to get some of your press releases.
Okay.
Flynn 128 at Comcast.net. Thank you.
All right. We'll have that sent out to everyone too, so that you could send back.
I'd
any
rather
questions.
have it piece by piece instead of
Yep, all right.
for 6 months.
Anyone else, any other comments? If you have any other thoughts or suggestions, we'll send them to John and he'll make sure they get reported. Thank you very much.
you.
I have a comment.
Yes.
I can't tell you how much I appreciate Kevin consulting with us and providing the media outlet that we haven't really had before. We've had other folks that have been involved in public relations and that type of thing, but as far as having a mindset just towards media and promotions and those types of things, I think Kevin's doing a wonderful job. He needs more money. And I think that's where he and I differ. That,
You mean a raise?
No, he needs more money to do his business.
Sure.
Media is
Oh.
not always cheap, and I think he's always looking for how can he reach the most number of consumers without costing the agency a lot of money. I mean, he would like a lot more of a spending allowance to be able to, purchase advertisements and billboards and those types of things. And,
Maybe you can get some grants.
yeah, there you go. We can work at that. But thanks, Kevin. I appreciate it.
All right, next item is, we need a motion to receive and file this report. Motion by Flynn, supported by Bush. All in favor?
Aye.
Motion carries. There's no additional reports. Don't you get, you can have other, you want your report now? Oh, it said report.
I've lost my status. That's supposed to say director's report.
I hit the, there's nothing behind it, and I thought we have nothing to report. Remember the
Do you want-
conversation we had in the elevator?
Yeah.
So just remember that
You
one.
want to do that now or?
Go ahead.
Okay.
Yeah, right.
So we'll start with the calendar, and then I want to pass out a few folders here, and we'll run through it real quick. Try not to get you multitasking here. Our program and budget for January 2018 is January 10. That's the next time we'll reconvene. The regular full board meeting is January 24. Both those meetings, 6 o'clock here. A reminder that our holiday open house is tomorrow at the Community Care Center on 15 Mile Road from 1 o'clock until 5 o'clock. And I'll defer to the chair the Board Association Spring Conference is going to be at the Radisson Plaza in Kalamazoo. Monday, February 5, which is, there's a pre-conference, and then the full conference is Tuesday and Wednesday, February 6 and 7. And I will defer to the chair to, for a motion for board and staff. What did I say? What conference did I refer to? Oh, I'm sorry. That would be the winter conference. Thank you.
Right.
Winter conference.
Someone had requested that we bring that up, but as long as you brought it up now, we could vote. You got a motion to allow people to attend? Is
The
that what you're
board and
looking for?
appropriate staff.
Yes. Joan, did you want to make that motion? All right. Is there support for that? Support. All right, any additional discussion? All in favor signify by saying aye. Aye. Opposed? Okay, so good, we got that in on time. Did you have anything else?
I do. I passed around a manila envelope with a little bit of material into it. I think I asked that you take it home, take a look at it, and this is something that is getting an awful lot of attention throughout the state of Michigan. And again, when you want to continue to be in the health insurance business, you know, a lot of what you're able to deliver in the way of services is predicated on the amount of income or the revenue that you have to your avail. And you've heard me mention before, I'm going to go through it again because it's that important, and it's being discussed at the state level with the Board Association. It's being discussed with the department at the administrative level. It's being discussed with GCSI, our lobbyist, who has a partnership right now, and I'll explain some of that, what we're doing. And it's also being, I think it's going to go to the legislature. And so any opportunity that you have as a board member to get the attention of the legislature on how damning this is to us, I mean, we need to ring the bell. Our consumers are paid. We get monies. We get buckets of money. For all kinds of consumers who have different types of Medicaid enrollment in the county. So hypothetically, or pretty close, not hypothetically, if there's 180,000 people in Macomb County who have Medicaid, as you know, that is our risk pool. We get paid for every consumer, all 180,000 people enrolled in Macomb County. Even though we don't service them, we get money for them. Many of them are enrolled as DAB, disabled, aged, and blind. Disabled, aged, and blind, a DAB consumer brings in right around $262 to us per member per month. Okay. Another group of consumers are Healthy Michigan Plan, HMP consumers. We get about $37.30 per member per month for those. And then another group, a very large group, are temporary assistance to needy families, the TANF consumers. We get about $16.68 per member per month. What is happening is when a consumer re-enrolls for Medicaid through the electronic CHAMP system in the state of Michigan, they may have been a DAB consumer all along. And what's happened just recently in 2016 and 2017, and all of a sudden, light on, we're losing Medicaid revenue. Let's find out and do an analysis what's going on. When they re-enroll, their DAB is being changed to HMP. And so instead of us receiving the $262 times thousands of consumers per member per month, we're receiving either the $37.30 or the $16 per member per month. So the PIHPs all went together and they did an analysis, and so 9 of them all got together and hired an independent contractor, and I didn't do that. I left Macomb alone. We had our own contractor already on board. Why spend money twice? So they all went with Raymond. I think there was a little conflict of interest using the guy that they used, but that's beside the point. So they went with Raymond to do their analysis, and we used a FIA. We used internal resources and used a FIA. Our methodologies and how we got to the end result were the same. And so statewide, there's about $100 million of monies that are lost to the PIHPs. And that's what this report says. $100 million that's lost to the PIHPs on the DAP gone, HMP gone TANF. For Macomb County in 16 and 17, we lost $6.1 million in revenue. So when the monies are shrinking as part of rebase, and I'm not being an alarmist here, I'm just telling you the facts. So part of the rebase that we're losing in the way of Medicaid dollars, not being able to use the utilization factor, now throw on top of this that we're losing revenue for the DAP gone, HMP gone TANF. And the department's aware of it. And the department position is, well, that's about 3% of your revenue. You're going to have to manage that within your risk corridor. They're not going to give up that $100 million. They're not giving it to anybody. So manage it within the costs of the risk in your contract. And so all the PHP directors, you know, they're having a little bit of an outrage on this. And further, they're publicly saying, if you can't manage it within your risk, we'll just outsource you. We'll just bid you out. And those are some of the notes that I put in here that they've been saying out loud relative to this issue. So for Macomb County, this is 16 and 17. We've lost $6.1 million. We're going to lose millions of dollars into 17 and 18 because the department is not going to change this. It's part of the new world, and you're going to have to manage your risk within your revenues that you got. And so if you turn to the next page, the Board Association is using this white paper, and it's just I won't go through it because it's everything that I just said. It speaks to $100 million. It speaks to Macomb County specifically there because some of the data that was given to the department didn't have Macomb's in there quite yet because ours was like 3 or 4 days behind. But they did make mention, and I spoke to Sheehan about the fact that we were equally represented relative to the transition of dollars. So this is the Board Association's position going before the department on the DAB gone HMP gone TANF issue. And so the concern is, and this is an interesting document, and some of you will really get a kick out of reading this one, I know Lou will. This, if you want to know where we compare with all the other PIHPs, that's the first time I've ever seen this, for 14, 15, 16, and 17, region number 1 is North Care in that first column. Region number 2 is Northern Michigan. You drop down to the bottom line on all 10 of these, and it actually tells you what their revenue is, their total amount of revenue. Like North Care, the whole Upper Peninsula has a $102 million budget. And then the whole Northern Michigan has a $169 million budget. And it actually shows you what their ISF is, their Internal Services Fund. None of them are fully funded anymore. If you look at Mid-State, in 2014, Mid-State, which is that whole big section through the middle of the state, they had $22 million, almost $23 million in ISF in 15. In 2016, they lost $9 million alone in their ISF. You want it more concerning the next time you see Jeff Brown, ask him how he's doing. And you look at region number 8. You look down on the very bottom there, and the ISF on the Healthy Michigan plan, he has no monies. There's no Healthy Michigan plan dollars. And his revenue is $295 million, and his ISF is only $14 million. I'm sorry.
You said Jeff.
Yeah.
Did you mean Willie? Did you mean Willie?
Yeah, I'm sorry. I'm sorry. Yep, I just was got caught in a little history there. So Lakeshore. So he has a $254 $4 million Medicaid budget. He has no ISF. He has zero, and he has zero for Healthy Michigan Plan. So we don't need to worry about Lakeshore. But the story here is what's going on with the DAB HMP TANF issue is that one or more PIHPs are going to be in the state's risk corridor at the end of the year. It's not specific who. And if this continues in the next 2 years, 4 or 5 people will fall into the state's risk corridor, not having any ISF. And Linda?
I have a question. What's the difference to the client in terms of their health care if they're on DAB versus Healthy Michigan and TANF?
They're indistinguishable, pretty much.
Same doctors, same everything.
So the one issue that we have going on is the DAB issue. So we're losing Medicaid revenue there. And the other thing that we need to be concerned about, everybody is familiar with Healthy Michigan Plan, right? Healthy Michigan Plan is a 4-year program, correct? In March, the maturation of that program comes due for the consumers who first enrolled. So in March, the estimate is that 20,000 people in Michigan will come off Healthy Michigan Plan every month. So in Macomb County, if we're 8 to 10% of the population, probably 1,800 to 2,000 people will no longer be HMP every month beginning March. So those consumers, we talked earlier about the importance of Medicaid, so those consumers are potentially going to hit our general fund if they need services through us. Joan?
You said we have somebody that's working for us, for these Medicaid people. Well, what's happening? How come we're not getting the people? You said we hired our own person to check the Medicaid.
We hired our own person to do the analysis.
Yes.
Yeah. So we're done. We're up to speed with the rest of the department. So the department, the Board Association, and Bob Sheen, when you see him or talk to him, ask him what's going on with the DAB analysis, he's representing all 10 PHPs at this point in time.
So we're all in a barrel all together?
We're all in together, yeah.
Huh.
The department is, I think there's a number of different fronts that are occurring, but the PHP directors are collaborating, working with the department, working with Senator McGregor, is it Senator? Yeah, I think he's the Speaker of the, not Speaker of the House. Yeah, I'm thinking, I'm drawing a blank on who Senator McGregor is right now, but we're working with Senator McGregor and also with the Board Association, and Macomb is working with Washtenaw County and Ottawa County lobbyists because we all share the same lobbyists, CGSI. So I've been working with the CEO of Washtenaw and Ottawa and having our lobbyists, and this Kirk Profit though, because Kirk is theirs, and Owen is, Gary Owen's been getting the message too, trying to bring more attention to the legislature on this because they're not going to do anything. The department is not doing anything at this point in time to provide any relief in this regard. So this is a big issue. When you think of all of our group home leases that we talk about, and the total value of those group home leases is about $3 million, $3.5 million. This is a $6 million problem going on for 2 years. And now with the Healthy Michigan migration, or the Healthy Michigan, those coming off Healthy Michigan, we just have to be very keen and pay attention to our revenue sources. And if we're going to continue to be strong advocates, as it's just the way it is anymore, it's always about money, that when we speak to Bob Sheen and any one of our representatives locally here, that they have a greater awareness and a knowledge of what's going on with this particular DAB issue. You mentioned DAB, and they should be able to understand what's going on. Or if not, we need to educate them. Any questions at all?
Linda?
Just to say that it's very troubling that these Healthy Michigan are falling off, considering how many people that we were able to get into treatment for substance abuse through Healthy Michigan, and that the crisis continues and the people aren't going to be eligible. And we don't have general fund money to pick up the lag. Terrible.
So we spent a lot of time administratively trying to offer the benefit that consumers have to their avail and to be fair with them and what is medically necessary. And a lot of times we find ourselves in a situation where, we can no longer, if a consumer comes to the door, hasn't met their spend down, as I indicated earlier, we just want to provide the services. We're in the business to provide the services, but we can't do that. Yeah, Brian?
So we've had a long discussion on the $7 million. And we mentioned the fact, we talked about discussing about sending a letter to get asked for that $7 million. I mean, this would just reinforce the reason why
Yep.
we need that $7 million.
Yep.
Not that we have a budget that's balanced. I mean,
Yeah, that letter will go out.
okay.
And so I wanted to bring your attention, to this topic. It's an important topic, and I'll continue to update you where we are relative to services and relative to finances as well. I think the board is interested in hearing more of what we do out there in the network. And so I have some speakers coming in over the course of the next quite a few months where you'll get 10, 15-minute presentation on the different programs that we do. Another thing I want to mention just too right now is we've talked about authority, reevaluating our situation on not to move to authority, but I think that if I can equate it with having a cardiac checkup, if you're feeling good and you had your heart checked, 20 years ago, that's good for you. And if you're still feeling good, but maybe after 20 years, you should have another checkup. And in 1997, we were feeling pretty good, and we had an evaluation on the risk-con or pro-con position that CMH may want to take on authority. And I've mentioned it before. I talked about it in my strategic plan. And I'm not sitting here as the CEO saying we move to authority. I'm not saying we don't. I'm saying that we need to be better informed, and I think we need to spend a little bit of money doing so. And before I was going to spend any money, I was going to bring you a statement of work. So I've been working with a firm to bring to you a statement of work that you'll see in January relative to engaging them on doing a study on what some of the other PIHPs have done relative and other CMHSPs have done relative to authority, what their successes and challenges have been, what are some of the things that we may want to consider if we do let an RFP for someone to do a comprehensive analysis, not only on the political legal side, but also on the financial side, what it would cost to pick up different departments. And the vendor that I want to use, it was eager to want to be able to come and present before the board and work at the direction of the board. And so I'm trying to line that up. But you will see the statement of work when we put the budget or when we put the agenda together on June 3rd. So before I spend any monies, I would ask for the board's consideration and approval of the statement of work, and then collaborate with the vendor over the course of the next 6, 8, 9, 10 months, and then perhaps bring a proposal back to Lease or let an RFP for someone to do a comprehensive study, but not to rush into it. But I think we should just continue to check it as we go along the way.
Anyone else? I have a question. You'd mentioned people coming off Healthy Michigan after the 4 years. If they still come to us, they've come out of the general fund, and that's because we are required to service people?
We're required to provide, per the Mental Health Code, emergency and crisis services. Mm-hmm. That's what we would provide.
And because they don't have coverage elsewhere, that's why it would come out of the general fund. I think we all know that, but I just wanted that shared again. Thank you. Linda?
I just want to say, that's not rehab. That's not any rehab.
No. Crisis.
No rehab.
So the last thing, and then I'll wrap up here, is I hedged my bet this morning and I mailed your Christmas cards to you prior to the vote. So I asked my wife for stamps, and she says, "You sure you want to do that right now?" So I appreciate the working with the board. I've always valued being a Macomb County resident and working in Macomb County Community Mental Health. I do like working with the board. I know there's a lot of challenges that are going on, and I know over the next few years there's going to be just as many that are there as well too. But we need people like myself, like the administrative staff, the board, who has that voice and continues to have the fight to be able to support those folks who need our voice. And so I'm optimistic for the next few years, and I'm thankful for the agreement that we have in place. And so with that said, I want to wish you all a happy holiday as well, too. Be safe.
Thank you. All right, next is item number 11, voucher listings. If there's any money left, does anyone want to make a motion to pay the bills? All right. Supported by Flynn. All in favor signify by saying aye.
Aye.
Opposed? Bills will be paid or have been and are approved. Are there any other agenda items? Seeing no other agenda items, we'll go to item 13, the second hearing of the public. Is there anyone from the public that would like to address this body?
Yes, I would.
If you would come up to the microphone there, please, and give us your name and address. You have 5 minutes to speak to the board. While we can't directly answer you, we can get information should you require it.
Thank you. My name is Sam Woodard, and I live on 22405 Glenwood Street in Clinton Township, Michigan. I've been working directly, actually been associated with the circumstances of our board for about a year and a half now. Jim Losey and Christina Ruitz have worked, and the board has to enable, I say the board, the Macomb County Community Mental Health, has worked to send my son, who's 26 years old, has Prader-Willi syndrome, to the Oconomowoc Prader-Willi homes in Oconomowoc, Wisconsin. And I just simply want to say we appreciate very much all the work that they did. It was a very difficult time, over a year and a half, to be able to get him placed. But he is there now. He was there November the 27th, and we're going to go to see him over Christmas. He seems to be adapting. It was a wonderful opportunity for him to be able to achieve as much potential as he can achieve in the circumstances there, as opposed to being where he was in our home for 26 years. He had reached his max, and he was needing to branch out. He was wanting to become more independent, and I appreciate Macomb County Community Mental Health allowing that to happen. We appreciate all you did, Jim, and also Christina. And a second thing I'd like to say, I don't know if it's possible, but if what you are reading could appear for us, that'd be tremendous on these screens. Would that be an extremely difficult thing to accomplish?
I think that's a possibility. We'll look into it.
Okay, no, I appreciate that. Thank you so much.
Thank you. Anyone else from the public?
Of course, it's the last time this year. Well, I'm not gonna come again. Lisa Lapine, Arc of Macomb, 44050 Gratiot Avenue, Clinton Township, Michigan. I was thinking as I was sitting there, I'm going into my 16th year at the Arc of Macomb, and I can hardly believe it. My youthful appearance belies that. But I've been there for 16 years now, and I think that Mr. Kinch and I would agree that probably this last year was the hardest year that this county has seen in those 16 years. I have offered public comment here more this year than I think I've ever offered at community mental health board meetings. And I figured if you didn't hear from me, you'd think something was wrong, and you'd be worried I didn't care. And I know that you know that can't possibly be true. In addition to having been at the ARC for 16 years, you guys gave me the opportunity to do more Medicaid fair hearings than I've ever done in my entire life in this last year. Even when I was employed by Oakland County Community Mental Health to represent them in Medicaid fair hearing, I have actually garnered more knowledge, more experience in this last year in Macomb County on behalf of the people we serve. So thanks for that opportunity as well. I say that in jest, but I do have to offer a compliment. You are represented by some incredibly able people through your corporation counsel. Mr. Thomas is a very caring, kind gentleman, and he does you well. You have some great staff from the Access Center who come and offer professional testimony. I seldom agree with it, but they do a remarkable job at being very, very supportive of families to the degree that they can when they're in a difficult position. So there's another compliment. I'm working on them. And I'm working on compliments tonight, right? Because it's December and it's that time of year that we be positive. That being said, I heard a lot of conversation tonight about still having budget issues. They didn't go away. They're not going away. They're not getting better. I would encourage you all to pay close attention to the policies and procedures that you're developing, because we continue to develop policies and procedures that expand our opportunity for dignity of risk, but also pose the potential opportunity for people to be at risk. I am the first to say to you that there are lots of folks out there who don't push the parameters of what's comfortable because we're scared, we're afraid, but we also have to be cautious about pushing too far into the realm of harm. And I really, really encourage you to remember that when these policies and procedures are put forth with the intent to improve the lives of the people we serve, with the intended consequence of also being a budget reduction or cut, we've got to be cautious about how we implement those, because at the end of the line, every decision we make in this county and that you guys make is about people. And I feel like a little bit this last year we lost our people. I also heard a little bit of conversation about the possibility of putting an RFP out there for residential housing. That to me signifies group home. Mr. Birdie, you said it yourself. It looks like we're moving more and more toward group home placement than we are to community-based living. We have the home and community-based waiver staring down at us. We don't know what the feds are going to bring us, but I'm not hearing a lot of planning for how we're going to approach or tell the feds that we're on the cutting edge of allowing people to remain in the community in homes like you and I live in, when we're talking about the development of additional group homes and continued cuts on CLS services. So I continue to urge everyone to look and keep their eye on the ball, that the people that we serve want to have the same ability to live the lives that we live in the community, participating in the community and doing the things that they want to do. And that doesn't necessarily mean congregate living in a group home, nor does it mean congregate support in a day program. And your day program numbers are up because your CLS dollars went down. More people are going to day program than have ever gone. But we're also challenging day providers to get people out in the community with less money than they've ever made. So we got to pay close attention to this, because some of this tension, it's not going away. We got to do more and more with less and less. The number of people we're serving isn't changing. Mr. Kinch gave us some numbers about the DAP that are important to know, because a little bit of knowledge to consumers and families would have kept them in the DAB column versus the Healthy Michigan column, and we would be bringing in a little bit of different money. So I encourage you, again, continue to partner with your providers, continue to partner with your families. We have the awesome opportunity to become cutting edge again, but we have to pay attention, and we have to build a better strategic plan about what we want to look like in 2 or 3 years. We have too many people residing on psych floor units for too long without the supports and services, and they can't get out. We moved too many people to adult foster cares and group homes in order to save money. And now we're faced with the challenge of kind of going back to where we were in the 80s. Bringing people back home in the community where they belong. I can't wait to partner to do more. I will not stop coming here and talking. I told Mr. Losi many, many years ago, if I stop talking, check, because I might be dead, okay? I'm not going to stop coming up here and saying this stuff, because the people we serve deserve lives of choice, and we've had to back away from that this last year. It's an unintended consequence of the budget circumstances we find ourselves in. But we have to continue to support folks and look at creative ways to serve. And I urge you to continue partnering so that we can do so. Happy holidays to everybody. Thank you.
Thank you. Is there anyone else that would like to address this?
I'd like to say something now. I'm sorry, but since Lisa got up, I'm a parent.
Sure, if you could.
Dave, you heard my son David before. My name is Earl Blumenberg. I've been a resident of Warren since 1957. I started with ARC when they were in a meeting in the basement of one of our parents' homes. A group of us got together and we said we're going to have to do something for our children that we're trying to keep out of an institution. So we organized a parents group. The first place that we had was on Amber in Warren. And it was a group of us parents, women, mostly the mothers, because the fathers were all working at the time. But we took all of the children that we could get together, and we had them doing craft work. And we would put it out in church bazaars or places like that to sell, to earn some money. Finally, we did get a little finances from the state, through the county, and we were able to broaden ourselves. We moved to a building out on Gratiot and 22 Mile Road. We kept getting a little bit more funding, but in the meantime, while we were doing all of this, we kept thinking, and I become president of the homeowners finally, of the group, parents group, and our executive director at the time, I don't know, maybe you've heard of him, Ron Kimball, I'm sure you've heard of him in Macomb County anyhow, was a very forward-thinking person. And he said, he got with me in early, he says, you know, we've got to do something better than these home-crafted things. We need to get these people that are functional. These are people. They're not developmentally disabled. They're not mentally retarded. They are people. We've got to get them out in the community. So we hired a person to go out and get them in the community. Now, you've probably seen plenty of them now. They're greeters in Walmarts and Kmart. They're baggers at Kmart and such. And I just want you to know that these are people. My son is a person, even though he's in a wheelchair, he is a person. He worked at one of your facilities over here on by the jail. It was a senior daycare. He worked over there, no charge. I used to carry him there every morning. I fixed his lunch. I went and picked him up at night. But those seniors that were there, most of them, I guess, were probably parents just wanted to get their father or mother out of the house and into something so they could do their things during the day. But they got accustomed to David. He used to take them out on their walks around the grounds. They would follow Dave around so that they knew where to go, and he would make sure that doors were open for them and such, until they got a new manager in who didn't think Dave would need it anymore. So he told me, we don't need Dave anymore. And I took Dave back home. But I guess I get emotional over these things, probably because I'm a parent, but I've seen what some of these kids could do. Well, I shouldn't say kids. They're young adults. I've seen what they can do in the community. And I think you people, as board members on community mental health, should take notice of it. And maybe if you go in one of these stores and you see one of those kids, give them a little pat on the back and tell them what a good job they're doing. That'll boost them up a lot. Thank you very much. And Merry Christmas to all of you. And we can say Merry Christmas now. We don't have to say Happy Holidays.
Thank you very much. Anyone else? All right. I lost my thing here, but I think our last item here is a motion to adjourn by Nagovan.
Sure, I'll make the motion.
All right, support by O'Connell. All in favor? This meeting is adjourned. Thank you. Yes, and this meeting is formally adjourned. We do have one other presentation here.